Welcome. I'm Artie Galarakis. And I'm thrilled to see so many USF Health alumni and donors online for this special event. It is my pleasure to welcome you to Confronting COVID-19, a virtual panel featuring the deans of USF Health. Thank you for being here today. The past few months have been a challenging time for the world, but I am so proud of the important work that our deans, faculty, and staff here at USF Health have done to fight the coronavirus. And what has been even more heartwarming has been the incredible generosity of so many donors who have supported the work we are doing right here at USF Health. Through this panel discussion this morning, we wanted to give you the opportunity to hear firsthand the impact your generosity has made in each of your colleges. I also want to thank the many alumni from medicine, nursing, public health, and pharmacy for how you are serving your communities during this crisis. Thank you. Now, it is my pleasure to introduce our moderator this morning, Mr. John Robinson. John.
Thank you, Artie. Good morning, everyone. You're listening to Confronting COVID-19, as Artie just said. This is a virtual discussion panel hosted from USF Health, and it's a venue where our USF Health alumni and donors can interact with our 4 college deans regarding the coronavirus, how it's impacting USF and USF Health and our surrounding Tampa Bay community, and USF Health's role in defeating this virus. As Artie said, I'm John Robinson. I'm an Associate Vice President at USF Health and your moderator today. And in just a moment, I'll introduce you to our 4 college deans. But before I do that, I want to take a moment just to talk to you about our venue today. Today's event is a Microsoft Live discussion for our USF Health alumni and donors. And that means that you as our audience will be able to see and hear our 4 college deans online. But to ask questions, you need to select the Ask a Question button on the bottom right-hand side of your screen and message us your question. Now, many of you were kind enough to submit your questions in advance of today's panel, and we would like to thank each of you who did that for us. We may not get through all of the relevant questions asked during today's discussion, but we will do our best. So let me introduce our panel of deans, please. And when I do, I'm going to invite each of them to give just a few opening remarks. First up, I'd like to introduce from the College of Public Health, Dr. Donna Peterson. Dr. Peterson, if you could, please.
Thanks, John. Good morning. It's a pleasure to be with all of you today. Thank you for tuning in. I know everyone's very interested in COVID-19. It's certainly changed all of our lives. I'm going to take just a few moments to talk a little bit about the virus and how we've been responding to it from the College of Public Health and with our colleagues across USF Health. So I'm sure you've heard COVID-19 described as a novel coronavirus. And the word novel, of course, means new, something new to us. And it is new to the human species, this particular coronavirus. But the word also means an invented story that is usually long and complex and deals with the human experience. So that's certainly how we are experiencing COVID-19. It is a pandemic, which means an epidemic that is worldwide. And we have not experienced a pandemic, though experts have warned we were overdue for one since the influenza pandemic of 1918. And while we certainly draw from that history of that pandemic, the world now is an extremely different place than it was in 1918. We have much more sophisticated tools at our disposal, more technology, more science, but we also have a population that moves more around the globe. We have a global economy, and we have a 24-hour news environment that we have to deal with. So as something new to us, COVID-19 has been challenging because we've had to learn about it as we go. We learn each and every day something new about the virus, and then how we respond has to adapt to that new knowledge. As a long and complex story, it has been impossible to put down. Every page we turn reveals more about this character and the many ways that it affects our lives. We know it is transmitted to person, via droplets that are expelled as we cough or sneeze. We believe it is highly contagious. The rate of transmission, what's known as the R naught, we believe is between 2.5 and 3.5, which means for each person infected, they then in turn infect between 2.5 and 3.5 other persons. We also believe there are many persons with the virus that have no symptoms of the virus. Hence, the consistent guidance from public health experts to maintain a physical distance of at least 6 feet between you and others around you to prevent the spread of the virus. Though early on, you may recall, we were not encouraging the use of face masks, partly because we had a shortage of face masks and other personal protective equipment, and we wanted to assure that we had sufficient quantities for our healthcare workers and our first responders. We now understand that face masks are one more way that we can help prevent the transmission, particularly in situations where we can't maintain that 6 feet of distance. So face coverings, and yes, they can be homemade, provide one more level of protection. We know that the virus can live for several hours, or in some cases several days on surfaces, depending on the surface material. Hence the consistent guidance from public health experts to wipe down frequently touched surfaces with disinfectant wipes or sprays containing at least 60% alcohol content, and the advice to wash your hands frequently for at least 20 seconds. Sing your favorite song. And when we say frequently, we mean frequently. Some people, as we've said, have the virus and exhibit no symptoms. Some experience only a mild illness. But the disease clearly can cause very severe illness and can result in death, particularly among high-risk populations, which include older adults and persons with underlying health conditions. Faculty, staff, students, and alumni from the College of Public Health have responded to this situation, providing staff support to the Florida Department of Health, appearing all over the media, designing a syndromic surveillance system for the county, and designing predictive models that have helped local officials make decisions. At the university level, we've convened a task force that I'm honored to chair, and we've been providing guidance to help manage our response over the past several weeks. We're now turning our attention to recovery and reopening strategies for the institution. I'm very proud that USF Health faculty and staff did an incredible job transitioning all of our courses to online instruction in just a matter of days to assure that all of our students could complete their courses on their way to earning their degrees and joining the health professions. As leaders of USF Health, we are accustomed to working together for the good of our students, our patients, and our community. And so it was completely natural for us to develop a collective, cohesive response to this emergency. The safety and well-being of our entire USF Health community has been our #1 goal, but given the importance of all of our areas of focus and mission, we have continued to teach, to engage in research, and to serve our patients in the larger community in all the ways that we can. I'm truly grateful to my colleagues for the ways we have come together to engage in thoughtful, comprehensive responses to this public health crisis. And I'm so very proud of our students who have exhibited incredible grace, patience, and persistence, and have cooperated with us every step of the way in every aspect of the COVID-19 situation. And with that, I'll stop and turn it back to you, John. Thank you.
Thank you very much, Dr. Peterson. So next, I'd like to introduce all of you to Dr. Kevin Sneed. He is our Dean of the Tunasia College of Pharmacy. Dr. Sneed, if you would go ahead, please, with your remarks.
Thank you, John. Just welcome to everybody that's online right now. We really appreciate your time. The Tunasia College of Pharmacy has really been active in terms of really trying to focus on research, medication delivery, and even participating with helping our practice plan implement telehealth and telemedicine here for our patients that could not come into the clinic. Many of you probably on TV have seen much about the repurposing of medication. What type of medication do we have available? What can we do? What type of clinical trials are going on? Here we have a cartoon, and I'm not going to take you through a full clinical pharmacology lecture. That would take you about 3 years of our great curriculum that we have here. But the real purpose of showing this to you is to help everybody understand that, number one, we found out about this virus beginning in December of 2019. And so we've only had about a 5 or 6 month period to really look at ways to treat people who are infected with COVID-19. Also, just to help you understand a little bit of context, from the time that we discover a medication until it makes it onto the market, that can be anywhere from 10 to 15 years. So we quite literally have not had an opportunity to build brand new medications to address the COVID-19 scenario as it unfolds. So what we have had to do as a scientific community all across the globe, we've taken a look at medications that were already either available and FDA approved, or were already in the pipeline of being tested for other conditions. And so here you see a lot of those drug targets that medications really have been focused on. Again, without taking you through a full litany of the mechanisms here, which people like myself, we read this every day and we look for drug targets. I will bring your attention to right there at the very top and highlighted a medication called tocilizumab, and then at the very bottom, we've all heard recently about remdesivir. In the very middle, we have the hydroxychloroquine. Each one is designed to have a drug target, a target designed to inhibit a portion of the replication of the virus. Some of these medications have already been on the market for other things, and then most importantly, we're finding that there is going to be some benefit for some of these medications, but not probably as targeted as we will have in the future. Many of the medications that we have right now will lead to other discoveries. We will continue to learn much more about these medications as we move forward, and then either alter that particular medication or build brand new medications that can help treat people going into the future. The other thing I would like to help you all understand is about the safety and efficacy of the medications. That's a big part of what we need to make sure that we're doing when we think about treating people with COVID-19. Very often we hear about a medication that may be very effective, but then also we hear about the potential side effects. We've heard that with some of the medications like hydroxychloroquine, that from the very beginning, we were very clear that we knew there were additional side effects that people could potentially experience. And therefore, patient selection would have to be very, very diagnosed and very selected in terms of which medications people get. The very last thing I would kind of share with you is just in the way of vaccines. We're hearing a lot about vaccines. It takes a long time to build a vaccine. Primarily, we want to make sure that we have to make sure, we don't want to, we have to make sure that the vaccine that we develop first has a safety profile that can withstand being given to millions of people. And so that has to have a lot of very vigorous testing in the very beginning. Number two, we have to make sure that the vaccine will only turn on the part of the immune system that we want turned on, and that it will not turn off other parts of our body functions. These are very things that we have to balance when we're trying to figure out what type of vaccine and the nature of vaccine. And that's why it makes vaccine development very tricky. And then third, we have to make sure that the vaccine is actually going to accomplish exactly what we intend for it to accomplish. I can remember early in my career, there was some vaccine development, and we found that the vaccine could get to the location, but it would actually kind of jump on the back of the virus and kind of ride around, but it did not neutralize the virus. And so vaccine development, we're hearing things about some very promising developments happening in Oxford. The pharmaceutical company Sanofi has actually supported what they're going to do and is going to be doing preclinical manufacturing. But we also have to keep in mind that until we know that that vaccine is very safe, that we will cautiously move forward with the hope that either that will unfold or other vaccines will unfold and be available to the public. Until that time, individuals like all of you, in terms of hand washing, social distancing, and other components and just supportive measures, if an individual were to become infected, are the things that we have to focus on. The very last thing I would share with you just about the Tunasia College of Pharmacy, we've really been focusing on teaching our students all of the cellular mechanisms far beyond what pharmacy programs have been able to do in the past. In the past of how we trained, a lot of it was really focused on organic chemistry and then application of medication and then communication with the patient. As we move into the future, much more personalized medicine in the way of pharmacogenetics and pharmacogenomics is going to be very critical in terms of treating conditions like COVID and anything else that may emerge into the future. And the really good thing about being here within USF Health, our faculty, our research faculty have already been collaborating with the Morsani College of Medicine faculty in terms of drug discovery and drug development. We've been partnering right now with our College of Public Health and College of Nursing in terms of getting out into the community. And we continue to provide clinical activity within our practice plan. So with that, I'll be available to answer any questions that you may have. But again, we thank you very much. And John, I will turn it back over to you.
Thank you very much, Dr. Sneed. And from the College of Nursing, our interim dean of the college, Dr. Usha Menon. Please go ahead with your remarks, Dr. Menon. Dr. Menon, I think you have to unmute yourself.
Thank you, John, and thank you also to my USF Health colleagues who have been such amazing partners to the College of Nursing. And I want to thank all of you who have tuned in today. It's such a pleasure to be able to share with you some of the amazing work and to highlight our students and our faculty and the work that they were doing across USF Health. I'm going to talk with you just for a couple of minutes about the impact this is having on the life of our students. And so just let me read to you a little story. This is the story of one of our students who is an ICU nurse. And at great peril to herself and to her family, she is caring for numerous patients who are dying from COVID. She works extended hours in a highly stressful environment. She comes home late at night from the front lines and then stays up until midnight to try and complete her schoolwork. She has 2 small children who are at home, and even on her days off, she cannot complete her schoolwork because she has to pay attention to them. Her husband does contract work from home for an essential business, and so he is working most waking hours and unable to provide much help. She remains in school, a testament to her resilience and to her persistence. And I know my fellow deans have numerous such stories to share with you. This is an amazing group of students who are working through this pandemic and this outbreak at this, truly extraordinary time, and being able to stay with their dreams, to stay in college, finish their coursework, to graduate, and then really join the healthcare workforce to make some of those changes that we know they can make. I want to share a little bit in terms of more specifics, and I know these are similar stories that you will hear from our other colleges. We in the College of Nursing converted 62 courses to online for the spring and summer. We have completed almost 600 virtual student admission interviews. We have admitted 317 undergraduates to our program and 526 graduates. And this has all been done through the virtual platform. We are graduating 229 students this week and next in the undergraduate and 144 across our doctoral and master's program. The College of Nursing faculty also received one of 14 USF Health COVID Rapid Response Research Grants. We do this in collaboration with the Taneja School of Pharmacy and the College of Public Health, as well as the Morsani College of Medicine. We will be developing a registry to examine the late and long-term effects of COVID-19 on social determinants of health of individuals living in Florida. And then I want to share with you again some amazing work that we're doing in the community. Our Community Affairs Office has developed bi-weekly community outreach. We are collaborating with the Sulphur Springs Community of Promise. We're continuing our collaboration with the Tampa Police Department to serve the children from the Rich House program. Some of you know and have supported this program in the past. We've distributed food, cleaning supplies, and learning activity books to over 100 families. And lastly, we are formalizing plans for our Seafarer Clinic outreach, and again, along with our colleagues in medicine and pharmacy. And we're also working on a Tampa-based street medicine for migrant care, specifically looking at the Wimama community that is in tremendous need now that many of them have lost their jobs. So again, thank you for your support. Thank you for everything that you are doing to help us keep academic continuity and to serve our constituents. And John, I'll turn it back to you.
Thank you very much, Dr. Menon. And from the Morsani College of Medicine, our Dean of the Morsani College of Medicine, and also our Senior Vice President of USF Health, Dr. Charles Lockwood. Dr. Lockwood, if you could please proceed with your opening remarks, and then afterward, we will begin with our questions and answers period.
Thank you. Good morning, everyone. First of all, I can't but reflect on what incredible colleagues I have, and you've just heard from all three of them. And you could not have asked for three better colleagues to have to combat a pandemic. I really have to say that the College of Public Health has been a godsend to me. I actually do have a degree from a College of Public Health, but it's got more like playing one on TV. But they've just been amazing, and to be able to access our fantastic College of Pharmacy and Dean to talk about all the clinical trials and what they are, and be kept abreast of all the different drugs and vaccine trials, and then our amazing nursing school and nursing dean, because nursing is really critical to taking care of these folks in the ICU. So I'll make very brief comments about the virus itself. You now know a little bit more from Kevin's presentation as well as Donna's, but this is an interesting virus, and it came from bats whose habitat was encroached by humans as part of the issues that we're dealing with encroachment of human habitation on natural environments. So domesticated animals became infected, and they in turn infected folks in Wuhan. The virus spread. The virus is completely sequenced. It uses RNA to reproduce rather than DNA, and it has 32,000 nucleotides. So we know literally every letter of the alphabet that the virus uses when it commandeers a cell's mechanisms to make proteins and reproduce itself. And that hopefully will provide some new targets for us. And we know that it has 29 proteins. And by comparison, the virus has 32,000 of these alphabet letters. We have 3 billion. So we make 20,000 proteins and about 100,000 variation of those proteins. It makes 29, and yet it's doing what it's doing. But each of those proteins has been defined and understood, and each represents a target for potential therapy. So the way the virus makes you sick is that it is spread by respiratory droplets, or when you touch a surface and touch your face and it gets into your respiratory tract, and it binds to that receptor that you all are now very familiar with, the angiotensin converting enzyme receptor, and it uses that to enter the cell, and that's how it reproduces. When it gets into the lungs, it gets into the little air sacs in the lungs, and it spreads and reproduces. But what really causes the problem is not the virus, it's our immunological reaction to the virus. And it fills those little sacs with fluid, and that's pneumonia. And that's why people talk about feeling like they were drowning. But it does something else really awful, and that is that the inflammation causes blood clots in the blood vessels that take the oxygen from those sacs. So it hits us two ways to deprive us of oxygen. It fills the air sacs with fluid, and it knocks out the blood supply to those air sacs. And I think that to the credit of our USF Health and TGH team, we've recognized that from the start, and we've designed our therapies to treat both those problems. And that's one of the reasons we have such a remarkably low mortality in Hillsborough County, and particularly in Tampa General. So that's kind of the basic medical issues. So how do you stop this thing? And there are 4 critical preconditions that a community must have to be able to move from what we do now, which is mitigation, slowing the infection so that it doesn't overwhelm our healthcare resources, to stopping it. And stopping it is basic block and tackle public health stuff, containment. It's what they did for smallpox or for dysentery at wells in England in the 18th and 19th century. So basically, those 4 preconditions are: you got to figure out who's sick. The problem with this virus, which makes it so insidious, is that about 75% of people, at least, that are infected are asymptomatic. They have no symptoms at all, but they're capable of spreading the infection. And that's mostly young folks. And young folks tend not to get as sick, and they can be asymptomatic spreaders. And you can spread the infection before you get sick, pre-symptomatic spreaders, and then you can spread it when you're sick. And so if we wait for people to get really sick to test them, we're not doing an effective job of blocking the spread of the virus. So we need tools, and these tools come in a number of different flavors. One is what's called syndromic surveillance mechanisms or networks, and they take symptoms like cough or fever or shortness of breath, influenza-like illnesses, and all sorts of other things, and use that to map a neighborhood that may be showing an increased number of those signs, even before they're tested. And Tom Unash at the College of Public Health has repurposed an old Zika surveillance tool for this purpose, and will soon be used throughout the state. And we're also trying to enrich that data with data from the Department of Health in the state, the so-called Merlin database, hospital databases, a variety of other sources, surveys, social media, anything we can get our hands on to identify those neighborhoods. Because when we can identify those neighborhoods, we can flood them with tests and identify the folks that are infected and their exposures and quarantine them and monitor them, of course. So the first precondition is this so-called surveillance, syndromic surveillance networks. The second, and you've heard this over and over and over from me and from others, test and trace, test and trace, test and trace. The problem with our testing regimen is that we have an imperfect tool. The test that we use now, the so-called RNA test or nucleic acid test, is looking for the viral RNA, and it means we're testing actively infected people. Now, the problem with that is 75% of patients are asymptomatic, so you got to test a lot of people, and you can't just test the symptomatic folks. Early in this terrible pandemic, the CDC was terrified that we would overwhelm our testing capacity, which was very limited, and our PPE, our personal protective equipment, because you need that when you're testing people. And so they had very rigid standards for who needed to be tested. You had to be really sick. You had to be hospitalized. You had to be over 65 and have comorbidities or either or. And as a result, a tiny fraction of the people that should have been tested were tested. Well, now we have much more robust capabilities for testing, much greater testing capacity, and fortunately, particularly in Hillsborough County, lots of PPE. And so we're able to now dramatically increase the number of folks that we need to test. And we need to test 150 people per 100,000 per day. That's a lot of tests. In Hillsborough County, that's 2,250 tests a day. In Florida, that's 32,000 tests a day. And we are committed to doing that. The governor is committed to doing that. And we're ramping up testing at a ferocious rate in the state of Florida. And in this Hillsborough County, in our county here, not all of you are in Hillsborough, but in Hillsborough County, we can do 4,000 tests a day. But last week we were doing 500 a day because we're maintaining these very rigid standards. So with the help of the mayor, the Hillsborough County Commission and the Hillsborough County Department of Health, the governor, the virtually all our elected leaders, we've now sent out the message, if you want to be tested, be tested. If you're concerned about being exposed, be tested. If you just want to be tested, be tested. If you have symptoms, be tested. If you're at risk, be tested. And now we've flooded the Hillsborough County testing sites, which USF Health is running and manning, as well as USF Health testing sites, as well as the urgent care facilities at BayCare, Evancare, HCA, and of course, Tampa General. So testing has gone way up, and we're getting very close to that 2,250 number. And the governor is committed to increasing the number of tests in the state to 20,000 by May 15th, by 30,000 by June 15th. He's even now talking about 40,000 by June 15th. So we're headed in the right direction. But the other part of test and tracing is tracing, and that's critically important. As the governor mentioned in his news conference this week, tracing is the most important thing we can do to contain the infection. Once we test somebody and we know they're positive, they need to be quarantined. They need to be followed. Our medical students are calling them twice a day to make sure they're okay, and making sure that if they deteriorate, they come into the hospital right away. They're doing that for the whole county. But in addition, we need to make sure that the folks that they've exposed are quarantined until they either get better after 14 days and get infected, or they become infected and we can start monitoring. So test and tracing, and we need a lot of tracers. Our fantastic College of Public Health has volunteered 61 tracers for the Department of Health. We need about 200 for Hillsborough County. And we need somewhere between 10 and 15,000 for the state of Florida. So again, we're working hard to ramp up. All the universities are committed, all the medical schools and public health schools are committed to providing tracers, and the Department of Health is doing a fantastic job of making sure that that happens. The third precondition that really will allow us to effectively clamp down this infection is what we call serological test or antibody test. You've heard a lot about that. Now, the problem with the RNA test is it has a 20 to 30% false negative rate. So we got to do a lot of tests to make sure we repeat test even to make sure we diagnose everybody. The problem with the serological test are false positives, falsely reassuring somebody that they have antibodies and they're immune when they're not. And that's because coronavirus may be novel, but coronaviruses have been with us for a very long time, and they account for 25% of the common cold viruses. So lots of people have antibodies to coronaviruses, and we got to make sure that these antibody tests are specific for what's called SARS coronavirus 2, which causes coronavirus infection number 19, COVID-19. And so we're working hard to figure that out. We have to figure out what level of antibody is protective, and we're going through all those validation studies now. The problem is that we've been flooded with a bunch of not such great tests. About 75 tests were flooded the market when the FDA relaxed its standards, and most of them are not good, to be honest. They have they have really high false positive rates. So at Tampa General, we're using a very good test with a relatively low false positive rate. But the problem is that the prevalence of COVID-19 in Hillsborough County is really low, 0.06%, which is great, best in the state for a large metropolitan area. But if let's say it's 1%, because let's say it's 0.1% because of the asymptomatic folks I mentioned. If you have a 1% false positive rate, and no test on the market has a 1% false positive rate currently, then for every one person that you correctly diagnose, you'll have 10 people that are false positives. That's a problem. So we're trying to figure out, can we use a titer of the antibody that's so high that you might have some false negatives, but at least you're not falsely reassuring people. There's a helicopter outside my office. It's a little concerning. And so that's another key thing. So we're working on that. But once we have a validated test, we can tell people they're immune, and then that's great because they don't need to socially distance. They don't need to do the other things that we're encouraging everybody to do. Last precondition is we can't overwhelm our healthcare system, and we're not. In Florida, we have plenty of ventilators, we have plenty of ICU beds, and in Hillsborough County, our problem is our hospitals are empty because we've done such an effective job. We've kept such a low rate of infections that in fact we're losing money. We're losing money as a health, and we're losing money at TGH, and we're very grateful that the governor is now allowing us to do elective surgeries again, which we really need to do. So I think I'll save most of the other questions or other comments for questions, which I suspect will come, but we're in great shape in Hillsborough County. We have one of the lowest case fatality rates in the United States, if not the world. We have a relatively low prevalence. We have aggressive testing. We've collaborated so well with our mayor and our county commission, as well as the state government, that in fact, we really have no major holes right now in the strategies we need to use to make sure that we can stop this infection. So lots of other things I could talk about. We have stood up a bunch of clinical trials. I can talk about that, including remdesivir that you heard about, and convalescent plasma therapy. We realized early on there was a shortage of collecting kits. And so we were able to develop very quickly a 3D printed swab that is now used by the state of Ohio and Virginia and many other hospitals and most of our hospital affiliates to test people. And that Summer Decker deserves tremendous credit for that. That was 1 week. Within 1 week of this epidemic, we were able to stand up telehealth. We had never done it before. Now we do over 1,000 telehealth visits a day. We created viral transport media to go along with this swab, so we had plenty of collection kits. And with Tampa General, we were able to stand up 6 different assay platforms to make sure we had adequate testing capacities. And we did all that validation. And our TGH USF infectious disease team, cardiologists, and pulmonologists have done an extraordinary job of saving lives and maintaining an incredibly low mortality rate at Tampa General, probably the best of any major teaching hospital in Florida and maybe the States. So kudos to those folks that are literally on the front line. It seems like 24 hours a day. And I can't say enough great things about the nurses and docs and respiratory therapists that are keeping these patients alive and allowing them to recover. So I'll stop there, but thank you.
Thank you very much, Dr. Lockwood. So we're about to begin our questions and answers period. Once again, you can ask your questions by selecting the Ask a Question button on the bottom right-hand side of your computer screen. And when you ask a question, we'll be able to see it here at USF Health. One thing that would be very helpful is if you would please indicate your name or how you would like to be addressed. And please also let me know if you are asking the question of any specific person on our panel. So with that, let's move on to the first question, if we could, please. And I think that I'd like to send that to Dr. Peterson. And the question is from Denise King. Have you designed a way for classes to resume on campus, and what does that look like in a classroom?
Thank you, Denise. Thank you, John. We are in the planning phases right now of how we may safely resume campus operations in the fall. And obviously, your question is an astute one, because one of our primary considerations is to maintain academic continuity for our students, but in a way that is safe. So we are looking at using all of the tools at our disposal. We have an outstanding capacity to do high quality online learning, remote learning, blended learning, and then some face-to-face instruction. So we're paying close attention to the data because we want to make sure everyone is safe. And if we need to maintain distance between students in classrooms, then we're going to have to reduce the numbers of students in any given classroom at any given time, which means that we may have to move some of the content online and reserve for that precious classroom space those instructional elements that are best delivered in a face-to-face way. So we're looking at all of our options right now, staggering when students come into a class, maybe having multiple sections for face-to-face, maybe even splitting the semester. So all of those things are on the table, and we're working hard on that right now so that we're prepared to welcome our students back in the fall in a way that is safe.
Thanks very much, Dr. Peterson. The next question I'm going to send to Dr. Sneed, and it's one of those questions that was sent to us within the last few days as we prepared for this panel. And the question, Dr. Sneed, is, does catching COVID-19 provide lasting immunity?
That's a very good question right now. We're investigating that all over the globe right now. Many of the antibodies that the body would produce in the way of what we call IgG or IgM, we know that they can be produced in a very short term, but we don't know if they remain what we call neutralizing. Neutralizing should you come into contact with that virus moving into the future. We're hopeful that it is, and we do know, as Dr. Lockwood mentioned, that individuals that have already been infected and produced the antibody, we can get that antibody in terms of convalescent antibodies and administer it to very ill people, but we don't know how long those antibodies will last in the body. And so your question is a very timely one. We're looking at it very acutely, and that may have a very lasting implication in terms of the type of vaccines and how often we may need to be vaccinated moving into the future.
Thanks very much, Dr. Sneed. And the next question I'm going to send to Dr. Menon because it's specific to nursing students. And the question, Dr. Menon, is as telehealth becomes the new norm, will nursing students be considered as part of the care team conferring with patients?
That's a terrific question as well. I think that we are definitely switching to what some of us have been calling the new normal. We currently have our graduate students, our nurse practitioner students in telehealth clinic, along with the medical students. We also have about 70 students who are cleared to go into similar situations for clinical just as soon as we're able to get them back out. So I think I definitely see an opportunity for our students to be able to participate in these sort of distance opportunities to deliver healthcare. I think it brings tremendous opportunity for us to work with the underserved, those who do not have access to care because of geography, or even because they're not allowed to come out of the house because they're vulnerable in terms of other chronic conditions, etc. Yeah. Back to you, John.
Wonderful. Thank you very much, Dr. Menon. I'm going to send the next question to Dr. Lockwood. It is from a person named Sherry. Dr. Lockwood, what are the thoughts of the panel members on the recent decisions by the state of Florida and Hillsborough County to relax safer at home orders? And specifically, would you comment on when you would feel comfortable eating in a restaurant?
Sure. Well, clearly, these are tough calls by politicians and political leaders. We simply can't stop the economy. The potential long-term economic consequences of not restarting the economy now are dire, and it is unprecedented. The fall in GDP, the rate of unemployment approaching 20%. Now are beginning to exceed levels that were attained in 1929 at the beginning of the Great Depression. So literally, this is a dire threat to the world and certainly the United States. And so decisions have to be made in a perfect world where the goal was just simply to protect health. Then we would continue the lockdown, but the long-term health consequences of that probably are greater than they are for reopening. I think it's also important to understand that we don't know precisely what strategy is best to employ. Now, clearly in the United States, we have many different examples. We have, the extremely and appropriately cautious approach taken in New York City, which is at the heart of the epidemic. Yet we have other states like Georgia, South Carolina, Tennessee, and Texas that have opened up and have not followed the president's task force recommendations of waiting till you've had 14 successive days of declining cases. So it'll be very interesting to see in 2 weeks what happens in those states. Now it appears that their citizens are much more cautious than their governors and are being much more prudent about reentering the workforce. I think that Florida did the right thing. So first of all, we've had more than 14 days. There's a couple of blips. It's kind of a sawtooth pattern, but in general, we've had at least 21 days of kind of linear slope of declining cases. We've had declining cases of incident-like illness, of influenza-like illnesses reported into the Department of Health, of cough and fever, and so as well as I note, of specific test diagnosis. And that's occurred, that rapid decline has occurred despite a dramatic uptick in testing. So we would have expected that, in fact, cases should have stayed the same, although hospitalizations are declining, and fortunately, death rates are declining. So, I believe that the governor did the right thing at the right time, very prudently. Secondly, he's made it clear this is not a switch, this is a dial, and he's prepared to dial it up or down. Thirdly, he had a much more prudent, he erred on the side of caution, a much more prudent set of reopening criteria than his own task force had recommended. So I think he's spot on. He's targeting testing and targeting and syndromic surveillance, making sure we don't overwhelm the capacity of our healthcare systems, and that's another part of the dial that he's created. And he's prudently approaching serological testing, not embracing it as some states have as a panacea. So spot on. In fact, if I were going to design a strategy, it would have been exactly the one that was rolled out. So I think it's good. I'm dying to eat in a restaurant, and I will definitely eat in a restaurant. Is one that I like to eat is open. But I expect that the server wears a face mask, that I get a paper menu, that everything is disinfected, and so forth. And, I'm theoretically in a vulnerable group with my age, but otherwise pretty healthy. So if I had a significant number of comorbidities, I might be a little more inclined to stay at home. I hope that answers the question.
Indeed. Thank you very much, Dr. Lockwood. The next question I'm going to send to Dr. Sneed. It comes from one of our anonymous audience members. Dr. Sneed, why did they pick famotidine for a trial, and what is it supposed to do? And if you're like many in the audience, including me, you might need an explanation for what famotidine is. Yeah. So if you would, please, Dr. Sneed.
Yeah, famotidine or famotidine is actually a medication that we commonly use for gastrointestinal or stomach problems. Many of you know it as Pepcid, over the counter. We've known about this medication for many years. It's what we call a histamine type 2 blocker. Many of us have these receptors in our stomach, and when we kind of eat the wrong foods or we have other abnormalities, we use that medication to try and calm down the acid production that can result from that. They have identified that chemically, the chemical structure of famotidine may potentially fit into the image I showed you earlier and actually begin to shut down part of the replication strategy for the virus when it enters into a cell. We don't know that for certain, and what I'm really concerned about, and I heard about this maybe 2 weeks ago, is just now hitting the mainstream media. But when I heard about it a couple of weeks ago, I was really a little bit more concerned because the dosing that you're using right now is about 10 times higher than what we commonly see used over the counter. And so typically, if you're using 20 or 40 milligrams over the counter, they're using doses between 200 and 300 milligrams. And they have to do it in a very continuous manner. And right now it's in a clinical trial. We don't know if it's going to work. Some computer modeling has shown that there may be a potential target that I showed earlier for famotidine, but at this current time, I cannot recommend and would not recommend that people go out to pharmacies and begin buying Pepcid and emptying the shelves of this medication, because at very high doses, we do have to be really concerned about renal function and side effects like headache and dizziness.
Thank you very much, Dr. Sneed. Many of our audience might not realize, Dr. Peterson, that you were selected by the president to lead a task force with regard to coronavirus. And so I'd like to send you the next question from Mary M. Barnes. Have anyone thought of how to help our Florida Department of Health and EOCs on how to assist with protocols implementation for hurricane preparedness for at-home as well as special needs sheltering for Alzheimer's disease and other neurocognitive disorder persons with challenges such as social distancing, sanitizing, etc.?
So thank you. That's another great question, and I'm smiling because I missed the weekly Emergency Operations Center call to be on this call, and that's one of the things we were discussing. You may know that the Yuengling Center on the USF campus is a special needs shelter for in the case of a hurricane. And we have been discussing how we will make sure that that special needs shelter is available and can be used in a way that also protects patients from COVID-19. We're also very actively working with the county in hurricane preparation, because the normal sheltering protocols aren't going to work necessarily in this case, because we do not want to be crowding people together if a storm should come. So we're looking at alternatives. That's all a work in progress, but you're absolutely right. The same messages that we have been giving around COVID-19, the distancing, the hand washing, sanitation, masking, all of those things are going to be as applicable during the hurricane as they were before. And perhaps even more important as we find ourselves with potentially large groups of people seeking to evacuate the area at the same time. So all of that is being addressed. And yes, our particular concern for those populations who do have special needs, who are at high risk, those are top of mind as we continue this planning process. That's a great question.
Thanks, Dr. Peterson. And if you wouldn't mind taking the next one as well, Brian Gerke, and Brian, I apologize if I mispronounced your last name, asks you specifically, when do you expect a decision will be made for having in-person classes in the fall?
Thanks, Brian. That's also a great question. We've been, our planning process, and I should say for a moment, COVID-19 is not your usual disaster. It's not your usual emergency. There will be no all clear signal, as my colleagues have already said. So we will in effect be in response mode and recovery mode at the same time. And what that means is we're trying to plan ahead as far as we can. We've been using a window of about 2 months. So we're trying to make decisions for 2 months hence to enable our colleagues, our offices, our professionals to plan appropriately for events that they may need to postpone or reschedule or reorient in this new, to not have face-to-face. And so the fall semester, which of course is scheduled to begin August 24th, at the absolute last moment, that means we need to make a decision, ideally by the end of May. We're hoping to make that decision before that, because we know lots of people have to then make their own decisions in regard to that decision. As I said earlier, in response to an earlier question, though, we are absolutely committed to offering a full array of instructional opportunities to our students in the fall semester. We will likely have some face-to-face instruction, but again, we need to maintain the distancing. And we are actually analyzing our classroom spaces right now to determine how many people can safely be in each room. So it may be that some portion of a class may be delivered online, but our goal is to have our students back and learning as we know they want to do and as we want them to do. It may not be totally 100% face-to-face, but likely there will be some face-to-face elements. It's a long answer to your question. We hope to have a decision by mid-May. Thank you for asking.
Okay, thanks very much, Dr. Peterson. I'd like to send our next question to Dr. Menon. And the question is from one of our previously sent in questions. As a hopeful future USF medical student, are the colleges of USF Health adding any training to the curriculum to prepare future health professionals for outbreaks such as the current COVID pandemic? Now, Dr. Menon, I know that you're the dean of our College of Nursing, but I think this is a reasonable question for all of our health colleges.
Absolutely, John. Thank you so much for the opportunity to weigh in. We have been very focused at USF Health over the past couple of years on what we call interprofessional education. And I know that's been a tremendous priority for Dr. Lockwood. So I think these questions are important for us to think and talk about in terms of that interprofessional collaboration that we do. Because in the real world, our students are going to go out and they're going to work with each other as professionals. They don't work in silos, only within the nursing community or the pharmacy community. So I think that what we have been doing is collaboratively looking at modules that we can add almost immediately to their clinical simulation education that looks at things like, how do you wear your personal protective equipment? How do you take it off? How do you protect yourself after you've been in a pandemic situation taking care of patients and then you go home? what are the measures that you need to put into place to protect your family? So we've started to talk about developing these modules to put into place that can then be sent out across all of our students. And these are the small things we can do almost immediately while we're kind of in this battle cadence. And then once we're out of this and are back to a little bit of business as usual, I think we are planning for more of these kinds of natural disaster preparedness, not just an event that happens one afternoon or a shelter from a hurricane, but really think about long-term effects on individuals' health. And back to you, John.
Thank you very much, Dr. Menon. We have had a flood of questions come in, and Dr. Lockwood and other members of our panel have graciously agreed to stay past noon. So we'll continue to with our panel past noon if you would like to continue to monitor our audience, and we'll get your question as soon as we can. I'm going to send the next one to Dr. Lockwood if I could please. Dr. Lockwood, you've had to answer a lot of questions about our economy. Lisa Montalayan, and I apologize, Lisa, if I mispronounce your last name, asks, we are in phase 1 of the state's plan to reopen the economy. With minimal testing, how will we know if we move too quickly? And how will we know if we can move to phase 2?
Thank you, Lisa. Of course, we all know Lisa. So the way this has been structured is it will be dependent on kind of real-time data being fed as to an increase in early warning signs through the surveillance networks I mentioned, and particularly at the state level, this would be an uptick in ED visits with cough, fever, shortness of breath, as well as influenza-like illnesses and a number of other parameters. So that's kind of the early warning sign. It would be an increase in hospitalizations. That's more of a lagging indicator. We expect an increased number of cases because we're ramping up testing so quickly. So, again, May 15th, we'll have 20,000 tests. June 15th, we'll be at the 150 tests per 100,000 per day criteria. So we will see an increase in cases as asymptomatic and minimally symptomatic patients are now being detected. Although, interestingly enough, those numbers have still not increased in the last few days. So that's a good sign. The other thing that the governor pays great weight to, which really reflects the physician recommendations to him, is the case positivity rate. So if you look at, I'm going to use 2 examples. If you look at Sarasota, Manatee, and specifically Manatee County and Hillsborough County, and you ask how many tests are being done relative to their population. So we have about 1.5 million. Manatee has about 400,000. We've done 22,000 tests in Hillsborough County. That's about 1.5% of the population. And our test positivity rate is about 5%. Now they have a smaller population, 400,000, and they've done about roughly, 4,000 people in Manatee. They've done about 4,000 tests, so about a 1% number. So a lot less than we have. But their case positivity rate is much higher than us. 85% of their cases are negative, 15% are positive. What we want is a number of positive cases of less than 5%, and ideally less than 2.5%. So we're going to be following at the state level very carefully that case positivity number. And as long as it keeps dropping, which it has been very nicely across the state, even in Miami-Dade, Broward, and Palm Beach counties, as that number keeps dropping, we'll know we're in good shape. If the numbers start to tick back, then you start to dial back some of the more restrictive requirements that we had in the early phases of the social distancing policy.
Thanks very much, Dr. Lockwood. Dr. Snead, you and I have done some work in East Tampa and some other places with regard to minority groups in Tampa. So I want to send you the question from Anonymous. Can any of you address the issue of disparities that exist with COVID-19? It is clear that African Americans and other minority groups are hit hardest regarding death from COVID-19. What needs to be done to address this issue?
That's an outstanding question. Myself and Donna Peterson probably more than a month ago, began having this conversation before it became a national issue. It's a very complex problem. Typically and usually, when you take a look at people of color and ethnic background, very often there are a constellation of different issues that become very complicating for this condition. For individuals who are diabetic, very often just being diabetic or having high blood pressure or some other condition that may be inflammatory creates an environment inside of the body that when the COVID virus comes in, it creates even more inflammation and kind of leads to a lot of the problems that Dr. Lockwood mentioned earlier in terms of fluid filling into the lungs, oxygen not being able to be exchanged in the lung. And so we find that in many communities where you have African American, Latino, and others that have higher prevalence of diabetes, higher prevalence of high blood pressure, these conditions, if you become infected, now create an environment that becomes very deleterious for the individual to be able to withstand. And so, for example, in Louisiana, I've been in contact with some of my former mentors and friends there. The total population of people, of African Americans in Louisiana is about 30%, but they represented 70% of the people that died. And we found very similar percentages in Detroit and New York and other locations around the country. If you take a look at Louisiana, Mississippi, Alabama, and then heading into parts of Tennessee and Georgia, right across there, all of the ethnic communities have been affected in a very similar fashion. But it's not simply just because of the virus. We're looking at decades old and maybe even centuries old challenges around access to healthcare and even to an extent social conditioning, whereas an individual may grow up and get to a point of not even wanting to or expecting to get good healthcare because they've never known it in their environment. And so the social determinants of health and along with being essential workers, travel patterns, it's a very complicated situation. My work with the Association of Black Cardiologists on a national level, we're diligently investigating it. But the one thing I can report to you, and I think I saw a question from Dr. Peterson, one of your former students in the College of Public Health here. I believe she's still in Orlando. I can state unequivocally that here in Hillsborough County, we have not encountered some of the very same disparities that we have found happening nationally. About 18% of the diagnosed cases here in Hillsborough County have been African American, and you compare and contrast that to about 48 to 50% of all cases being Caucasian. And so we're really paying attention to it, but I would invite my colleague Donna Peterson to add on to anything that I said, but we are paying attention. I think we're doing a little bit better job here. Of course, Miami, the Miami-Dade and Broward County areas were a little bit harder hit. But again, that concentration in population really had a lot to do with that.
Thanks very much, Dr. Sneed. Dr. Peterson, would you like to comment as well?
Sure, just to affirm everything that Dean Sneed has said, and this has been a concern of ours for quite some time because we know that our African American populations in particular have higher rates of the diseases that Dr. Sneed mentioned, which creates a more severe environment for the disease. But we also know that part of the reason they have more of those conditions in the first place is because of the many, many, many years of systemic and structural determinants of health that put African Americans in unhealthy communities, create high levels of stress, do not create the same access to healthcare and quality care, all of the things that he mentioned. So I think you see in COVID-19 the culmination of the result of an inattention to the social determinants of health, in particular for the African American community. Everything from housing to transportation to education to jobs and healthcare. And that's what we see. And it was entirely predictable. And we're seeing it now. And we're very hopeful that not just in this issue, but that our experience with COVID-19 will give us an opportunity to rethink a lot of our policies and the ways we approach health in communities across this region and the state and the nation. Thank you.
Thanks very much, Dr. Peterson. Dr. Lockwood, I'd like to send you one of the questions that was sent to us within the last couple of days, and it has to do with returning to normal. The question is, are there more targeted strategies for flattening the curve that target those who are at high risk rather than society as a whole?
Yeah, so that's a really good question. If you look at the Swedish approach, which has been entirely different than ours, it's really to achieve herd immunity by really sequestering older folks and at-risk folks and letting everybody else get infected. And they're up to about 30% immunity at this point based on their estimates. So a very different strategy than what we've taken on. And their rate of fatalities is higher than it is in other Scandinavian countries, but it's not incredibly high. And in fact, it's a little bit lower than the United States, which is obviously taken the flatten the curve approach, which is to push out cases so as not to overwhelm our health systems. So, I think what we've decided to do in this country is to do everything we can to minimize the number of folks infected, with the hope that over the next 6 to 18 months, we'll develop first more effective therapies like remdesivir, and then secondly, a vaccine. And if we do have a vaccine, as Dr. Fauci and others have suggested might happen as early as the beginning of January, that would be a world record for a vaccine. The average vaccine can take up to 15 years to go through its various proofs of efficacy and so forth. So we'll see. I mean, I would be really pleasantly shocked if we have a vaccine. But our job really right now is mitigation, to keep the curve flattened. I think we can, in certain areas, move to containment that maybe even further reduce the number of cases in a more permanent way. And then hopefully we will have a vaccine and we will have better medications that dramatically reduce mortality rates.
Understood. Thanks very much, Dr. Lockwood. Back to Dr. Peterson. This is from Megan. Do you have an anticipated timeline for when faculty and staff may be expected to return to campus?
Thanks, Megan. Thanks, John. No, we don't, quite frankly, because as I said before, we're really monitoring the data, and we are in the midst of very comprehensive planning to consider how we can create a safe environment, or the safest environment possible, and enable people to do their work. I would make sure everyone understands the campus is not closed. There are a number of people on the campus now who are providing essential services, certainly people in our research labs that need to keep their experiments going, people that are maintaining our facilities and our grounds, our health staff, of course, are there. So it's not at all closed. And many people, quite honestly, have, I think, successfully transitioned to remote. In some cases, they're more productive than they are in the office. And so we're really looking at, we are for students, a phase-in approach to easing people back in, starting with those who are needed to perform functions that then will enable other groups of people to come in. So as an example of that, our instructional technology people have been incredibly important in this entire process as we've transitioned to distance learning and to telework. They've been working around the clock, and I think a number of them are eager to get back to campus so that they can continue to use and develop the technological solutions that will enable us to go forward. So they're assessing their workspace right now to make sure that they can perform their work in ways that allow them to maintain distance between each other. So that's part of the analysis that we're doing now. So again, it will be a phased-in approach. But the experience that we've had with this, and we are not unlike other industries that we've all been reading about, that have found that maybe telework's not such a bad thing. I think it's been something that people have been reluctant to embrace because of concerns. Would people actually work? Would they connect with their colleagues? And while there is absolutely something lost from not being together in the same space, I think we're finding this technology works quite well. So I think when we come back, it will not be back to where we were. It will be a new normal, as people have said. So it will be an easing in of our faculty and staff over the next few months and probably well into the fall. Thank you.
Thanks very much, Dr. Peterson. I know we've all been pretty amazed at how efficient everything has been in remote operations, much more efficient than we ever expected. And Dr. Lockwood has a lot to say about that as well. But first, I'd like to go back to Dr. Menon, if I could, please. Dr. Menon, what has been the impact of the coronavirus on enrollment and academic programs?
Thank you, John. I'm really pleased to say that we have not seen a tremendous downtrend in the College of Nursing. Our students come in on a cohort basis, so if they choose to sit out, it takes a long time for them to catch back up. So for the majority of our students who had committed, we're seeing them continue to complete their paperwork, to make their deposits, etc. I couldn't speak specifically to the other colleges, of course. We also didn't see a tremendous dropout through the spring semester. There may have been a touch and go here and there for a couple of students, and I think that speaks specifically to USF Health as a whole and our university helping us kind of pivot to put changes in place for the students. So we put some changes in place to the grading policy for many courses. Faculty relaxed some of their due dates and the coursework and assignments, not in any way to lower standards, but just giving students the ability to be able to handle the competing demands and then also complete their coursework. I know pharmacy has put some very robust things in place related to their graduation and getting their students out into the healthcare workforce more quickly. So at the moment, I think we're holding our own, and I hope that will continue through the summer. And John, back to you.
Thanks very much, Dr. Menon. So Dr. Sneed, I'd like to send you a couple of questions that we received over the last couple of days. The first question, and I'll give them both to you. The first question is, do you think COVID-19 was present in Florida in 2019? And the second question is, how accurate are the tests, false negatives and false positives? Go ahead, please.
I'll answer this question very quickly and in combination with my senior VP, because I think we both shared a lot of interest in this area. Number one, I don't know if we have any definitive evidence that COVID-19 was in Florida prior to anyone knowing. I think in California, we have determined that COVID-19 was probably present long before we really knew, and the first official diagnosis had come, I think, in Washington. However, there were a number of people that were reporting very odd types of flu, that when they had a flu test done, it was coming back negative, and a lot of them came back negative, and they were told that they had respiratory viral syndrome. So, and we don't know whether or not those individuals were infected. I think the only way that we can figure it out now would be very aggressive serology testing around IgG and primarily IgG to see if people have built up antibodies. And even if they were not diagnosed at one point, we may be able to determine that later. I'll let Dr. Lockwood address the question about the sensitivity of the exams, because he's done a lot more work in that area than I have.
Yeah, so there's a biological limitation to how sensitive the nasopharyngeal swab is in being able to detect the virus, and that is that not all cells are infected, not all cells in the nasopharynx are infected, not all cells are releasing the same amount of RNA, and so there really are limitations to how that site can have a better sensitivity. There's some evidence that the saliva might have a little bit higher level of virus, but it also depends on the amount of virus that particular person is producing. So there's a 20 to 30% false negative rate with the nucleic acid RNA test that tells you that snapshot that whether you're infected or not. And the antibodies, it's the opposite problem. It's the false positives. With the FDA approved test, the better test, there are about 7 now in the market that have specificities, which is the inverse of a false positive rate, specificities of around 95% or better. But we really need specificities of close to 100%. And so we're working on trying to lower those false positive rates by figuring out the level of antibody that will permit us to define someone specifically is immune. There's some other tools we can use to define who's immune or not, including whether they had the illness, they confirmed to have the illness, they're now better for 72 hours, 7 days after they were diagnosed. That's a good indication of immunity. And of course, repeated negative RNA tests are a very good indication of immunity. And if you have all three, then you have a 99.9% chance of truly being immune. So there are some things we can do currently with the antibodies to better define whether people are immune, but we're concerned about that false positive rate.
Thanks, Dr. Lockwood, and we'll keep you up there for just a second if we could, please. This is from Anonymous specifically for you. Wouldn't we expect the case positivity rate to decrease over time as testing expands and we move from testing those with symptoms or illness to those who may not have any, the asymptomatic or pre-symptomatic? I agree that the positivity rate increasing would be a major cautionary flag, but is a static or slightly decreasing positivity rate evidence of anything other than expansion of testing to more asymptomatic people?
Yeah, that's a really great question. And so the case numbers will go up, but the case positivity numbers will decline unless, of course, there is an increase in the rate of infection. So it's an imperfect tool, there's no doubt about it. But given the fact that we have that high false negative rate, and given the fact that so many people are asymptomatic, the only way to get around it is just to do many, many more tests. On the other hand, if you're Manatee County and 15% of your tests are positive, you got a problem.
Right. Thanks very much, Dr. Lockwood. Dr. Peterson, how can we turn the opinion of the public and politicians who say the stay-at-home orders should be cut back due to lower than expected cases, when in fact the numbers are as low as they are because of the stay-at-home orders?
Well, this is the classic dilemma in public health. Whenever we seek to prevent something and we are successful, we are criticized for having spent money to prevent something that didn't happen. And so this is kind of the same thing. I think the early decisions to ask people to stay at home again were designed to help prevent transmission, particularly to those most at highest risk, to help keep us from overwhelming our healthcare system and to buy us time to further learn about the virus. I think all those things were the right things to do at that time. Yes, they created immense hardship, but we simply didn't know enough, and it was the right decision to make at that time. So doing so absolutely has helped keep the increased rate of transmission lower than had been feared. Clearly helped us not overwhelm our hospital systems and our healthcare system, and did buy us time to learn more about testing and tracing and antibody testing and potential treatments and all the things that we've been discussing here today. But it is time, as Dr. Lockwood and others have said, it is time to now reopen slowly, albeit slowly, to continue to protect our highest risk members of our community and to monitor very carefully the impact of those decisions. So as we move into next week with a lifting of the strictest versions of the safer at home order, not all businesses are reopening. People are still encouraged to not gather in large groups. People are still encouraged to maintain physical distancing, to wear face coverings when out in public, and to keep up the hygiene. We'll see what happens. And if people can cooperate with those relaxation, not complete lifting of the safer at home order, then we may be fine. But if we see an uptick in cases or an uptick in the case positivity rate, then we may have to impose those restrictions again. So to me, I think it just speaks to, from the very beginning, like any public health approach, it has to be collective. Public health is what we do together as societies to create conditions in which we all can be healthy. And this is a great opportunity for us to show our collective wisdom and our collective strength and to follow these directives in the spirit that they are intended. Yes, we need to reopen our economies, but we need to do it slowly because our ultimate goal has to be to protect the health and safety of our community. It's a great question. Thank you.
Thanks very much, Dr. Peterson. And I understand from our producers that we're going to have to wrap it up very quickly in just a couple of minutes, but I'd like to send the last question to Dr. Lockwood, if I could please, because it's a question that I hear quite often. And this question is from Danielle. Dr. Lockwood, what are the thoughts on essential domestic air travel? Can you comment on when you would feel comfortable traveling on an aircraft instead of traveling long distances in a car or some other means?
Yeah, I've been frantically trying to answer some of the questions. That was one of I was just about to push reply on. The problem with obviously with domestic, or no one's going to fly internationally, but the problem with domestic air flights really are that you can't socially distance. You're packed in like sardines in the old days. Now it's a little bit better. So if you absolutely have to travel, your grandmother is sick and you have to fly to Wichita, I would say, number one, for sure, wear a face cover. And hopefully everybody on the plane is using a face cover, and the flight attendants are using face covers. Number two, bring some disinfectant. So a package that you can open up and wipe down the seats and everything you touch. Number three, use a hand sanitizer. I would say use it like once an hour at least. Make sure it has 60% alcohol. And obviously, if you can sit away from folks, try to do that. The part of the air filtration systems of planes are a little bit of a concern. They're in economy class, I think there are 6 air exchanges an hour or something like that. A little bit better in first class, but so that people are sneezing or coughing. Well, not much you can do if you're sitting one seat away from them. So, if you can avoid travel for now, I would, but if you have to, I would take those precautions.
Thank you very much, Dr. Lockwood. Well, I want to thank everybody today. It's been a terrific discussion. We've had a lot of great questions. Unfortunately, we're going to have to bring it to an end. And I apologize that we didn't get everyone's questions answered, but if you have additional questions, I'd like you to send them please to advance@usf.edu. Again, that's advance, ADVANCE @usf.edu. And also, if you'd like to help support the research and care being provided in the fight against COVID-19, please consider making a gift online at usf.to/pandemic. Every gift is going to make an important difference as we fight this pandemic. Again, the place where you can make a gift online is at usf.to/pandemic. Every gift makes an important difference. Thank you, everyone, for your participation today. We wish all of you a very pleasant afternoon.